afternoon. Good afternoon, commissioners. Welcome to the December 15th meeting of the Maryland Healthcare Commission. You have before you the agenda, and at the outset I'd like to announce that one of the items will be removed from today's agenda and rescheduled, likely for the next meeting, and that is the presentation on the overview of Maryland's Comprehensive Primary Care Program. So we'll go forward with the agenda as presented with the absence of that presentation. So with that included, commissioners, in your packet are copies of the minutes from the November 17th commission meeting. If there are no changes or corrections, I will entertain a motion for approval. Discussion? All in favor?
Aye.
Any opposed? Thank you. The motion has passed. Commissioners, you've received the written updates, as always, voluminous updates on our centers. Any questions before we, on the written updates, before we ask Ben for his overview? I think we're budgeted for new microphones.
Great. My question was just under the cost and quality analysis collaboration with the MIA on rate review. It talked about the MIA's, the staff should link to the Price Transparency Initiative's website, which displays the MIA's public version 1 of the cost and utilization dashboard. Is that publicly available now?
So, yes, the public version of that is available now. We showcased that a few months ago, but I'll make certain you have a link to it. The MIA also has another dashboard that presents more detailed information by health plan that is not publicly available.
Has there been any has the industry seen that? Has anybody sort of?
So the comment that I'm aware of has come from several consumer groups that have looked at it, but we have not, as far as I'm aware, gotten specific comments from the industry. What I would say is that the industry, as they've worked with us and the MIA to align the reporting of the rate filings with the submissions from the all-payer claim database, what we call the medical care database, there's greater focus on the completeness and accuracy of information that's coming through the APCD and recognition that over time the APCD, the all-payer claims database, could be an important tool for supporting and understanding rate requests made by individual health plans.
Okay. I just think it may be something very useful for industry that's doing the rate filing to see how the information is transmitted.
Well, I think the one long-term vision that only one state has made significant progress in, and that's Massachusetts, is that it is at least technically feasible to think that the all-payer claim database could be the vehicle through which rate filings were made. But as I said, only Massachusetts has made significant progress in that direction up to this point. It is our goal to do that, but we're taking incremental steps forward.
Right.
And certainly accuracy and comparability between the rate filings, these are these aggregate filings that all health plans submit to the MIA, and what is contained in our database, reconciling those two and understanding differences in denominators, populations, and total costs are important first steps.
Thank you.
Ben, do you have other updates?
Yeah, I had a couple things I wanted to note. Early this month, we met with the health plans. As you know, for a number of years, the Maryland Healthcare Commission, almost 20 years, has been reporting on health plan performance. And as over time, we have evolved those plans to include greater detail and more specific information on Maryland privately insured populations. We've also added information on race, ethnicity, language, and cultural competency. But as our budget has tightened, we recognized that the consumers in particular are very focused on performance of providers and perhaps less so on health plans. And we concluded that for our report due in 2018, we would relax some of the requirements related to our reporting, consumer reporting, and our HEDIS reporting from the plans, that rather than requiring Maryland-specific results, we would accept information that the plans are submitting to NCQA as part of their plan certification accreditation efforts. This will save us a significant amount of money. It will also reduce some of the additional costs that health plans absorb, and we think it will allow us to focus those funds on a greater emphasis on provider reporting. The 2017 report will be released as planned, but beginning with our report that will come out for 2018, which is based on 2017 experience, we would reduce our reliance on Maryland-specific results. I think that's appropriate given our funding challenges that we're looking at over the next couple of years. Secondly, last month you approved for release draft proposed regulations for freestanding medical facilities. We've gotten some additional comments from interested parties. We have decided to delay publication of those proposed regulations until we have had an opportunity to discuss those proposed regulations with some of the elected leaders that played key roles in the passage of Senate Bill 706 last year, and make sure that as we go forward with the freestanding medical facility regulations, there's good clarity on the scope of the original enabling statute, as well as an understanding of the authorities of the respective regulatory organizations, including not only MHCC, but also HSCRC and the Office of Healthcare Quality. The second item, and this somewhat parallels our work on freestanding medical facilities, I wanted everyone to know that we are moving forward with a work group on changing our regulations regarding ambulatory surgical services. That meeting will be held in early January 6th. The purpose of that meeting is to develop a exemption process for existing ambulatory surgical facilities that have one OR and wish to establish two. A second focus will be on establishing a framework for converting hospitals to establish on a freestanding medical facility campus ambulatory surgery capacity. We expect that the work group will meet approximately twice, and would expect to have some regulations back to you in the early draft proposed regulations in the early spring. We are also moving forward with some efforts on our transparency front. Last fall, you saw a presentation from Francois de Brandis on the episode of care work that they are doing in collaboration with the MHCC. We are decided to focus on 6 surgical episodes of care initially. They include total NIP, total hip, and total knee replacement, as well as vaginal delivery, colonoscopies, endoscopies, and hysterectomies. That we have already constructed episodes of care for those 6 categories of service. Our next step will be to work with the hospital industry to make certain they have an understanding of what we're doing going forward, and we'll update you likely at our February meeting and our plan to make this information publicly available. What is somewhat complicated is the fact that we are doing so many things in Maryland that the concept of episode of care means different things to different people. And although it's broadly endorsed as the way forward, these methodologies differ enough that they can be confusing if you're not attentive to every detail. So I think it's appropriate that we are careful and engage the organizations that would be the subject of the episodes of care to make sure they understand the directions we're going. That concludes my update.
Thanks, Ben. Any questions, Ben? Any center directors have any additional updates to share with the commission?
Hey.
I just want to make a quick comment on the FMC and the process that's going with regard to that. So the intent will be for those regs to come back to us for additional consideration.
So the intent is to make sure we understand any concerns that the elected leadership or parties have. I'm hopeful that they could go forward and be published as proposed regulations. If that were the case, they would come back to you for adoption as final. If we conclude that the proposed as drafted need to come back, then we would do so at the January meeting, and they would be again proposed regulations.
So when I after the meeting, I had an opportunity to talk with some of the folks who had written some of the letters, and I was under the mistaken impression, my fault, that the differences with regard to what we had included in the proposed regs and what the parties had requested with regard to those were inconsequential differences. And I think they're very consequential. And having had more time to consider them, I think what we have accepted as proposed represent dramatic limitations on potential innovation and our ability to, as a state, to develop those freestanding medical facility concept into one that could provide value at decreased cost to consumers. So I'd really like to see an opportunity for us to take another look at them.
So the first step is to make certain that staff believes that we have flexibility under the proposed, but we want to be sure we understand, to your point, parties concerned that there isn't enough flexibility, and we'll keep you updated absolutely going forward. I think one of the big challenges with the freestanding medical facility regs, and it's a function that this is a evolving concept as we move forward. What was conceived of and adopted in April of last year after considerable debate, and probably don't want to go too far into that today, but after considerable debate, has evolved over the last 6 or 8 months, and what was thought of in April is not necessarily what is thought of in December of 2016. It's our hope that these regs would provide the flexibility, appropriate flexibility, but we certainly will be mindful of some of these concerns.
Other questions about that? Now, center directors, any additional updates? Nope. Okay, thank you. Well, then with that, we'll shift to the next item on the agenda, which is an action item on the annual mandate report. And I believe since that doesn't occur that frequently, a little bit of background and context would be worthwhile. So Maryland law requires that the MHCC annually assess the impact of proposed mandated health insurance services that failed to pass during the preceding legislative session, or that were submitted to the commission by a legislator by July of the previous year. This spring, the MHCC received a formal request to assess proposed mandates for coverage of lymphedema treatment, and digital tomosynthesis for breast imaging. Staff also received an informal request to assess the impact of long-term antibiotic treatment for Lyme disease. Staff will respond to the Lyme disease inquiry by noting that recent clinical trials have found that long-term antibiotic treatment does not have additional beneficial effects on patients with persistent symptoms attributed to Lyme disease. The reports on lymphedema and digital tomosynthesis are due to the General Assembly by December 31st. The Commission's consulting actuary, Donna Novak, founder of Novarest, and Karen Bender, Novarest subcontractor, will present the report. As both consultants will be joining us via webinar, Janet Ennis will be at the presentation table. Thank you.
Thank you, Chair Phillips. Levon is, you can unmute, are they unmuted? In the screen, Levon? Okay. And Donna and your team have been unmuted. You can start your presentation as soon as you're ready. Donna, can you hear me? Karen?
Oh, I'm sorry. This is Donna.
Go ahead,
This is
Karen.
Donna. First, thank you for allowing us to attend today, at least virtually, to present the summary of our reports. I'm Donna, the founder of Novarest, and I'll let Karen speak in a second so you recognize her voice. I'm going to start the presentation with the lymphedema, and then Karen is going to do the presentation on the 3D mammograms. So Karen, you want to say hello so everybody knows your voice?
Sure. I'm Karen Bender, and both Donna and I are actuaries with probably more years of experience than we care to admit.
Yep.
And I've had the opportunity to work with the Maryland Healthcare Commission in a previous life, so I too welcome the opportunity to talk with you today. I'll turn it back over to you, Donna.
Okay. Next slide. Okay, so just a little bit of our qualifications. We've done over 40 mandated benefit evaluations in 6 states. Novarest, including Karen and myself and other team members that worked on this report, have a combination of industry and regulatory experience. And we've done rate development as well as quite a bit of rate review lately. So we know what goes into estimating the impact of any new benefit. Next slide. Want to note that our reports include information from multiple sources. We did make sure that all of the sources were credible, but in order to present an unbiased report, we have presented both sides where there is any conflict. And we're not actually presenting our opinion, we're leaving it to the reader to make a decision on both of the benefits. Next slide. There are 2 important elements for a mandated benefit right now. There's the ACA benchmark plan, which in the case of the lymphedema, well, first is the Care First plan, but in the case of lymphedema, there are some limitations right now. It's limited to 30 visits, pre-authorization is required, and some of the compression garments are not specifically mentioned in the benchmark plan. And as you probably know, any new mandate under ACA would have to have some financial support from the state, and it would take an attorney to determine if the new mandate goes beyond the benchmark plan. Also, the Women's Healthcare Rights Act requires services to be covered that are physical complications of all stages of mastectomy, including lymphedema. So under the Women's Health Care Concert Act, some coverage is mandated already. We did ask carriers to include any limitations they have, and our report shows any limitations that the carriers might have beyond what is required by the Women's Health Care Act. Next slide. So the mandate for lymphedema is under House Bill 113, which would require the insurers or carriers to cover anything resulting from the medical or surgical benefits, and that is medically necessary in diagnosis, evaluation, and treatment of lymphedema. The coverage may be subject to deductibles and copays and coinsurance, and to the extent that the carrier would impose those on for similar coverages. Next slide. Lymphedema just generally is caused by any loss or damage to lymph nodes, and the lymph nodes are responsible for cleansing the body of waste out of the tissues. And so if there's damage or loss of lymph nodes, the fluids build up. And most of the time, the damage to lymph nodes is from cancer treatments. So according to the medicine.net, lymphedema is defined as the swelling in one or more extremities that results from this impaired flow of the lymphatic system. The symptoms are a feeling of heaviness, tingling, tightening, swelling, pain, and if this continues, there can be a decrease in the ability to even see or to feel in the extremities. There'll be a tightness of jewelry, clothing because of the swelling, redness of skin, and if this continues without treatment, the symptoms become more and more pronounced and more severe. Next slide, please. Medicare does not cover lymphedema, the compression supplies, because it doesn't fit under a Medicare category right now. So, and in Medicaid, the one MCO that responded to our survey indicated that the treatment for lymphedema is covered when medically necessary. There is criteria that has been established in Medicaid, and the devices are covered if the individual has been compliant with more conservative therapies such as elevation, exercise, massage, compression bandages, and if those are not working and the lymphedema is not improving, then the compression devices, garments, are considered medically necessary and would be covered by Medicaid. Next slide, please. So we did survey the carriers, and we had 4 carriers respond to our survey for lymphedema. The first carrier considered 2 pairs of compression sleeves or gloves per affected arm every 6 months. They considered other compression garments for other areas as experimental and investigational, and therefore do not cover them. The second carrier will cover the compression stockings and other garments with a pressure of 20 mm or more, and they will replace the garment every 6 months. The third carrier has established criteria for determining whether a compression device with and without the gradient pressure is medically necessary, and those criteria are in our report. The fourth carrier will cover the pneumatic compression devices in a home setting for the treatment of lymphedema if the patient has undergone a 4-week trial of conservative therapy, being treated by a physician to determine, and if there's no significant improvement in the lymphedema, then again the device is considered medically necessary. Next slide, please. There have been studies performed in other states on the impact and premiums for a lymphedema mandate. All of the states have pretty low estimates. They range from 10 cents to 11 cents PMPM. We did our own estimate, and ignoring that there is coverage in many cases today in Maryland, we would estimate a maximum impact between 6 and 7 cents. But in reality, since there is so much coverage already available, our estimate would be significantly less. We were not able to get any data on what percentage of patients currently are covered, and so we couldn't do an estimate of what the mandate would cost on a marginal basis. Next slide, please. We had been asked to look at some additional issues beyond just the cost of the mandate and the impact on premiums. We would not expect any significant impact on the cost of the service. Mandates often increase utilization and demand and impact the cost, but we would not expect that in this case. We would not expect a significant increase in the use of the service because so many carriers are already covering it in the situation where we normally see a need for the result of lymphedema and a need for the garments, which would be due to cancer treatments. But there may be some increase. It's not really a substitute for a more expensive service. There would really also be no impact on administrative cost at this time. And again, no real material impact on the cost of health care in Maryland. Given the low cost or estimated cost of the proposed mandate, it is really unlikely that the passage alone would cause a major shift to self-insurance by small groups or large groups. Next slide, please. So that's really our analysis of the lymphedema mandate. And before I turn it over to Karen, I'll ask if there are any questions.
Thank you, Ms. Novak. Questions for Ms. Novak? Mr. Pollack.
Yeah, so thank you. That's a great presentation. I want to ask, in your discussions and in your analysis, you sort of presumed that all the lymphedema that was being treated under this mandate is associated with post-mastectomy in cancer patients. But lymphedema occurs in other patients as well. It dramatically broadens the market or the potential cost, ultimate cost of this mandate. And oftentimes a diagnosis of lymphedema is used, and I've seen providers use a diagnosis of lymphedema and prescribe the modalities to treat it in patients who have not had lymph node dissections, don't otherwise have lymphedema, and otherwise wouldn't be effectively treated with these things. So what in your analysis limits this discussion to post-mastectomy lymphedema and prevents somebody from listing a code for lymphedema and prescribing treatment for it under the same mandate?
Yeah, Thank you for that question. We didn't really assume that the lymphedema was all due to mastectomy. What we did not have is any data to estimate what the occurrence of lymphedema outside of mastectomy or with mastectomy. So our 7 cents estimate is based upon if there was no lymphedema treatment covered right now, which is not true. So the actual cost would be significantly less because lymphedema due to mastectomy is covered as long as it's considered medically necessary. And the report goes into more detail on how the carriers determine medical necessity. As far as diagnosing lymphedema when in fact there is no lymphedema, I can't really speak to that. We did talk to some providers about the treatment, and but we did not get into the diagnosis.
This is Karen Bender. Let me emphasize again, I think Donna made the point well, that when we asked the questions for the carriers, their answers were not limited just to lymphedema benefits related to cancer. They covered all lymphedema.
Thank you. Questions?
Yeah, this is Dr. O'Connor. I think the issue is bigger than just, I think you should clarify the lymphedema into acute and chronic. Like Dr. Pollack said, there's a lot more causes of lymphedema than you state here. And most of those are transient lymphedema, post-surgical, just overloaded, the local lymphatic, so forth. I think what you're referring to here is chronic lymphedema. And I agree, the number of patients you'll see with chronic lymphedema would be quite limited. But the fact of the matter is, when you say lymphedema, that if you want to include acute lymphedema, that's quite extensive.
Okay, this is Donna again. Thank you for those comments. The data that we used was the all-payer claims database, so it would include claims for lymphedema treatment from all causes and from temporary as well as ongoing.
So just to be clear then, your estimates of the increase in PMPM was for all cause, chronic and acute, without distinguishing those post-mastectomy versus other lymphedemas that were recorded in the all-payer claims database. Is that correct?
That's correct. It would include all treatment of lymphedema.
So just to further clarify, that the individuals in Maryland who would be subject to this mandate, should it pass, would be those who are not post-mastectomy because they're already covered in a different mandate. Only those who are members of a commercially regulated carrier, not self-insured, not Medicaid, et cetera, et cetera. So that's the universe. It's the non-mastectomy, commercially insured lymphedema, both acute and chronic patients that would be eligible for this coverage. And those that are not currently in a plan that provides that coverage. So just to make sure I understand we understand the universe of who would marginally be affected by this change. Is that correct?
That's correct.
I don't know if I made that clear or not, but any other questions? Yes.
Thank you. I'm interested in the bill itself, which I haven't seen yet, and I imagine we'll be hearing about this from our legislative consultant. But I would like to be certain that if such a mandate is extended, it will cover all chronic lymphedema. Because I do, for instance, I know a young woman who at 21, college athlete, due to failure to diagnose chronic compartment syndrome, developed chronic severe edema in a lower extremity and is still today at the age of 33 wearing compression stockings, which she purchases herself. But for a person who's not able to go out and buy those, they're very pricey. she's going to have this the rest of her life. And I want to make sure that we're covering that sort of occurrence. I'm very sensitive. It's interesting to me to hear Dr. Pollack describe cases where there's potential for abuse in the short term. But I want to make very certain that if we're going to talk about mandates, that we're covering the kind of patient who is going to have a long-term chronic problem due to other causes.
Thank you. And let's just ask, if I could ask Ben to clarify the Commission's role right now with respect to this report and to separate from legislation. Okay, so let's just get that framed.
So this has been a historic responsibility. Some who were with the Commission prior to the implementation of actually passage of the ACA in 2010, we encountered these requirements quite frequently where at this stage we're not required to weigh in on our position. We're required to give an assessment of a bill that did not pass. Should a proposal come forward in the 2017 session, the Commission would have an opportunity to take a position independent of this assessment. We're providing almost like a Congressional Research Service or a CBO-like estimate. We're not compelled to take an opinion. We're providing this, and historically we've done a number of things. We've passed these reports through after the Commission has determined they're acceptable. We've passed these reports through with a statement that there were concerns about the growing number of mandates. That we passed these through with the concern that this might be an appropriate mandate. So I think independent of the study, in the cover letter, we have some flexibility in how we would respond. And we would then, just one final point, if this comes forward, then the Commission could look at that legislation and depending on positions, advise the legislature on the scope. Was it appropriately defined in law?
Thank you.
Yes, thank you very much for the presentation. I've read your report fairly closely, and what I'm trying to figure out is exactly what the actual impact of a mandate would be as you recommended, because in your report, Donna, you make it very, very clear, at least clear to me, that all carriers already cover lymphedema, and they cover it on the basis of medical necessity. It's also clear that the Medicaid program is covered for lymphedema on the basis of medical necessity. I guess my question is there such a variation in medical necessity determinations for this particular condition that it would require a mandate on something that is already being provided by the insurance industry in the state of Maryland?
Yeah, that's a good point, and one that I pondered also when writing the report. We didn't specifically, we asked the carriers about any limitations they had, but we didn't ask them about any limitations due to the cause. And it's clear that if it's due to cancer, especially mastectomy treatments, it would be covered. But we didn't get any data to estimate this, and we didn't specifically ask the question, but there seemed to be enough anecdotal information that there were situations where it wasn't as clearly medically necessary and it wasn't due to a cancer treatment that the carriers were not covering it. It would be, I think, a small percentage of the lymphedema treatment, but it would be obviously important to those individuals where it wasn't covered. But that was primarily anecdotal information.
Yeah, my concern on this is that as a regulatory body, I mean, our concern here is to make sure that we impose when we agree to such a thing as a mandate on an insurance company, that there is in fact a strong reason to do it. And based on your report, given the fact that all carriers already can basically cover the condition for lymphedema, I don't, speaking for myself here, not the rest of the commission, obviously, but I don't see a point in passing or imposing a mandate unless there is actually a substantive reason for doing so.
Other comments, Dr.
Just another comment, just so people aren't confused that all edema is lymphedema. In fact, more commonly, it's not lymphedema. And I wonder if you have any diagnostic criteria that you need to identify the edema as lymphedema, as opposed to all you see down here in the audience, just look at your ankles and see if you have any swelling. That's edema. So I just want to know, is there any criteria that you use where you diagnose lymphedema?
Are you asking me, Ms. Donna?
Yes.
Okay.
I saw a test that you use, and those commonly used in other diseases like vascular disease in the extremity, not so much to identify lymphedema. But more commonly, what I'm trying to get at is edema. I don't know if it'll be more cost to the insurance industry if all edema is treated as lymphedema, is what I'm saying.
Right. The bill states lymphedema without giving diagnosis criteria, and the data we used was under the codes for lymphedema, but we would not know how it was determined that it was lymphedema instead of edema.
Any other comments? So we are being asked here, thank you for your report, Ms. Miller. We're being asked as a commission to review this report, and this report being the actuarial report on the potential impact of the mandate. And as Ben described, should the commission choose to approve the report going forward, we have some discretion, quite a bit of discretion, in terms of how we characterize the report in a cover letter that could conceivably be simply a transmittal letter. Here it is. Here's what our consultants have determined. Other options that we've exercised in the past have been to put some skids, to put some considerations on this particular mandate, or alternatively to recognize that this is perhaps crucial to a very appropriate mandate and crucial to a deserving population. So I'd like to do two things. I'd like to first ask for a motion on the approval of the report itself, and have some discussion. We can vote on that, and then have some discussion on the nature of the transmittal letter, how we want to characterize that. Yes. So move. Second. Is there a second? All in favor? Opposed? Thank you. We have our report then. Discussion on how to characterize this mandate, this assessment of this proposed mandate to the legislature. Mrs. Solomon.
So there's one sentence that just jumps out at me, and this is following on what Commissioner Moffitt commented on page 13, where it starts at the top of the page. All carriers cover lymphedema when medically necessary. I'm going to read the description of what is the question, and it's that lymphedema should be covered when it's medically necessary. So if I were to write a cover letter for this report, I would, my focus would be more on if there is an indication of a need, meaning that the coverage isn't there, then a mandate should be considered, because there clearly needs to be something happening that's not happening. But it appears to be happening. So the mandate feels to me like overkill, unless there is some evidence that the coverage is not present.
Thank you. Other comments?
I agree with that completely, and I can picture what's going to happen in the context of a mandate. In the context of a mandate, I will have manufacturers of lymphedema supplies in my office teaching me how to code for the use of these things under the mandate to get them covered, because the insurance companies won't be able to back away or negotiate with this in the context of a mandate. I agree completely with what Commissioner Stallworth has said. I think we ought to, but I think in addition we need to define a need. We ought to ask that the legislature define a specific need for an uncovered service in this area prior to creating new mandates and potentially new costs and new markets.
Thank you. Other comments? So a couple of things that we heard about the ambiguity of actually the kind of edema, whether it's regular run-of-the-mill garden variety edema or lymphedema, if it's chronic or acute. Those are some somewhat technical considerations. But the greater question that a number of commissioners have raised is, what is the need for this mandate? What exactly is the need? And so with that, and perhaps the spirit of the commission then is to frame a transmittal, a cover letter that really directly poses those two questions back to the legislature, bringing forth the report itself, but to convey the spirit of our discussion here.
If I could, I'll comment. So we did not track this bill last year, and we were at the time thinking that we would not be responsible for this, doing these mandates. After the session, we did get these letters. I think that way I would characterize why there is although characterize why there's concern is really related to the supply. I think that there's no question that diagnosis of lymphedema is covered, but although we don't have this in the text, the frequency in which you are eligible for the lymphedema bandages that restrict swelling is apparently questioned among some beneficiaries, and I think that is why the legislation came forward. We could look at the legislative history on this to see if that came out in any of the testimony, but I think although it says diagnosis, treatment, and supplies, I think the focus was on the bandages, which can be, if they are custom made, quite expensive. And is there some consistent framework that a mandate would establish, such as the frequency of replacement, et cetera, that may ensue? I think that's where it is. I think our analysts got very accurate information that carriers provide benefits, but there is some disagreement about how frequently bandages should be replaced, et cetera.
Just a follow-up question with that. I guess I'm just thrown off a bit by the summary on the slide 5, that it says HC 113 would require insurers. I'm not going to read the whole thing, but basically require them to provide coverage for the diagnosis, evaluation, and treatment. It doesn't say anything about compression. I mean, if that is so, is this about compression garments? And is that what the bill was considering, or is it about the treatment? Because I think we're getting really specific, and that's fine if that's what the mandate is, and that's what the report should be focused on.
Well, I think that we're responding to a legislative piece of, a bill, but I think I am surmising that and maybe this is largely anecdote on my part, that some of the concern is how frequently these bandages are covered, under what constitutes medical necessity for getting custom-made bandages as opposed to something that can be purchased. So,
well, and what constitutes treatment? Because how one might determine treatment and how that's defined, it seems like there's an assumption being made that treatment is the compression bandage. And again, that may be completely appropriate, but that's not what this says. So it seems like if the mandate is about the compression bandages, then that's what the report should be about.
We're responding to the bill, and it is broadly diagnosis, treatment, evaluation.
Technically speaking, again, I'm sure the insurance industry already pays for chronic venous stasis edema. This would add very little, I think, to the overall cost to cover chronic lymphedema, which is very debilitating if it's truly lymphedema. What I'm saying is, if the industry is already paying for stockings, which would be the same stockings for lymphedema, the difference would be the pneumatic type of treatment that you give, that ordinarily you don't give to venous stasis, but you would give to lymphedema. But to me, that's the only big difference. I don't know what your criteria are to go to that pneumatic type of vasoactive type of compression. But what I'm saying is, you know, industry's already paying for venous stasis edema, and this adds very little.
I think that was what the report concluded as well. Is there another comment? Yeah, Mr. Moffat.
Yeah. First of all, I think we can justify, I mean, in any given case, and we've seen it happen over and over again in state legislatures, where they'll have some particularly difficult case, and they come forward and they say, look, this is a particular problem. It's usually based on an experience that maybe the legislator had or whatever came before them, and they will request a mandate in the insurance industry. So, you know, you have these particular problems, and as a result, basically what you get is you get a multiplication of mandates. In this report, the authors make a very interesting observation about the impact of the mandates over time, and it's the impact really on the fully insured market. They point out that the percentage of private sector employers offering health plans of which at least one was self-insured, meaning they were not under the state mandated benefits, increased from 28.5% in 1996 to 49% in 2015, representing a 36.8% increase. And then the authors go on to say, this is a vitally important point, and if we communicate this to the legislature, this will be very beneficial for them to hear it again and again and again. It is not the cost of any single mandate that drives employers to self-insure, but rather an accumulation of multiple mandates. Maryland is one of the most highly regulated states in the union. We are paying for that in excessively high health care costs in many cases. And very, very high health care costs, as you all know, contributes directly to uninsurance, pricing tens of thousands of our fellow citizens out of coverage. So we ought to keep that in mind, and when we make a communication to the state legislature, we ought to remind them of some of the fundamental economic consequences of their actions.
So, Ben, do you think you have the context or the color for the cover letter that would apply a healthy dose of caution about mandates in general, about the deleterious effect of mandates in general on the market, recognizing that this is a report that responds to the language of the bill, which was lymphedema diagnosis and treatment, and that the punchline, the bottom line was that the universe that was studied has minimal impact, but either on the cost or on the likelihood of future migration to self-funded plans. Do you think you have enough that you could share a draft with us and we could move that forward? Is that satisfactory to everyone?
There's a piece that I think is, I still go back to the focus on the compression sleeves, and we're making assumptions. If the mandate is a broad mandate, then the conclusion of the report is that the coverage is there. If there's something more specific that's meant, that should be clarified. I guess that's the piece that.
Right. So responding to what I understood Ben to say, the bill itself was broad, and this assessment is likewise.
It's broad, right. And if there is there's an issue about something more specific, that is not addressed.
It didn't come out in the bill, and it didn't come out in this report.
And I think we need to look at the bill a little bit further and see if there's any hidden meaning in that. And Aaron and I will look at that before we draft the response.
This is just very briefly to Commissioner Moffat's point. it's not maybe just the bill, but how it emerged. And if it emerged in the context of an individual suffering, then that should not be lost in terms of the tone of the letter. So we're responding to the bill, but there's a human being maybe somewhere in there that led this legislator to do this. And that should not be lost in the tone and the spirit.
Thank you. So, Ben, we'll trust you and Aaron. We'll put together something in here. Sure. Thank you. Let's move to the next proposed mandate, the next report, which is on the coverage of 3D mammography. And I believe that Karen Bender.
I'll turn it over to Karen.
Okay, can everyone hear me all right?
Yes.
Okay. House Bill 1006 essentially requires that 3D, I'm going to call them 3D mammograms, or technically digital tomosynthesis, but that's hard for me to say, so I'm going to call them 3D mammograms, will be covered the same as 2D mammograms. You want next slide, please? This slide provides some basic statistics related to breast cancer. Breast cancer is the third leading cause of cancer deaths among women in the United States. In 2016, there's an estimated that 247,000 women will be diagnosed with the disease, and about 40,000 will die of the disease. It's most frequently diagnosed among women aged 55 to 64 years of age. The median age of death from breast cancer is 68 years. And mammograms are the diagnostic tool used in the early detection and diagnosis of breast disease, and most notably cancer in women. Next slide, please. Traditional mammograms is the means that has historically been used to be the diagnostic tool for breast cancer. They use an X-ray system that takes images of the breast from two angles. One of the limitations, shall I say, of traditional mammograms is that doctors often cannot distinguish between lethal cancers from non-lethal cancers, especially for what's called ductal carcinoma in situ, or DCIS. So therefore, all women are treated as if the cancer will be life-threatening, even though for a significant percentage of women, this cancer will never break through the ducts and then never spread into the breast. But however, at the current time, like I said, doctors really have no means of distinguishing between the types of cancers that will break through and those that will not, meaning that all the women who get this diagnosis are treated as if the cancer does break through. And this is what's sometimes called as overdiagnosis, since a large percentage of the women would never experience a breakthrough. This becomes important later on because an increase in the frequency of the diagnosis of DCIS could increase this overdiagnosis. Mammograms may also produce a normal result even though breast cancer is present. And currently the rate of recall for women having 2D mammograms is about 104 per 1,000 women. And anytime that there's a recall, it means that there's more diagnostic testing that has to be done because there's some anomaly shown in the mammogram. Next slide, please. This slide provides a quick summary of 3D mammograms. And unlike 2D mammograms, 3D mammograms take multiple images of the breast from different angles, and they're reconstructed or synthesized into a 3D dimensional image set. And a lot of radiologists believe that they have a clear image of the breast and are better able to observe and detect any abnormalities better than in the 2D. Now this is especially true for women with dense breasts and or women who've had breast surgery or radiation or some other type of treatment that would impact the breast tissue. Now, several studies have found that the 3D mammograms find more cancers and reduce that number of false positives. So the rates of women who have to come back for more testing are reduced with 3D mammograms, which, again, as I said before, whenever you have to come back, there's going to be more tests, either mammograms, ultrasounds, biopsies, all of which add to the overall cost of health care, as well as the psychological stress for the women who are being called back. Next slide, please. This slide cites various studies on the medical efficacy of the 3D versus the 2D mammograms, and quite frankly, the results are mixed. The National Cancer Institute indicates that there has not been randomized studies comparing the accuracy of the 3D to the standard mammogram. However, we've also seen that the rates of internal cancers, and those are the cancers that are found within 12 months after a normal mammogram, did decrease slightly with the use of 3D mammograms versus 2D mammograms. And a longitudinal study released just very, very recently provided evidence that the benefits of the initial 3D mammogram screening can be sustained and actually improved over time with consecutive 3D mammogram screening. And a study of 13 hospitals found that the rates of DCIS detection, that's what I referred to before as being a source of overdiagnosis, remained at 1.4 cases per thousand screening. So after switching from 3D from 2D, so it didn't really increase that percentage of or probability of overdiagnosis. Next slide, please. Now, this is where we get into some more differences of opinion, I guess, would be the best way of putting it. The U.S. Preventive Service Task Force, which is the basis for defining what constitutes preventive benefits under ACA, has concluded that there is no inconclusive evidence that stage 3D is essentially better than 2D. They also recommend a biennial screening of mammography for women ages 50 to 74 years, and the screening for women aged 40 to 49 is an individual decision. Normally, the recommendations from this task force have to be grade A and B in order to classify as preventive under the ACA, which then makes it a requirement that these services are provided without any cost sharing. CMS did sort of overrule, I shouldn't say maybe enhance, and indicated that they weren't going to implement the screening for age 40 to 49 as a grade C, but to continue that as under A and B. Now, Medicare started covering 3D mammograms in January 2015. However, currently, with the one Medicaid MCO that responded to our survey, 3D mammograms are not covered in the Maryland Medicaid program. Next slide, please. The current coverage, there is variation among the carriers. 2 carriers consider 3D mammograms as experimental and investigational because of insufficient evidence of its effectiveness, and they both cited the results of the U.S. Preventive Task Force as the basis for that. One carrier covers 3D mammograms 100% when medically necessary, but the individual would have to demonstrate a reason why 2D would not meet the needs. Two carriers, which are currently insured, the majority of the insured market in Maryland, cover 3D mammograms, same as any other mammogram, but they began covering them in 2015. Next slide, please. We looked at the financial impact from various perspectives. There were a couple of states that had made similar proposals. California estimated the premium increases to be very minimal, 13 cents to 20 cents PMPM. Connecticut Care, which is Connecticut's insurance exchange, estimated that a 3D mammogram mandate would increase premiums by $1.38. However, Anthem, operating in the same state, indicated that there would be no impact on the premiums. We also asked the carriers to provide their estimates. Obviously, the two carriers that currently cover it, theirs would be zero. And the others had a range from 20 cents to about 20 PMPM, which is very, very minimal, only 0.1% to 0.3%. Novarest independent estimate range from 0.1% to 0.18% on a gross basis, and the reason for that variation depends upon the assumptions pertaining to the percentage of total mammograms that would switch to 3D, and also some variation in the additional cost per mammogram, which is anywhere from about $50 to $100. But it would really drop on a marginal basis, and one of the reasons for this is that the majority of the market, because these two large carriers currently cover it at 100%. And I should also, they currently cover 3D the same as 2D. And I should qualify that although preventive mammograms are covered at 100%, there are times that mammograms are done for reasons other than pure preventive. And whenever mammograms are done other than pure preventive, they are subject to any cost-sharing provisions of the contract, the same as any other procedures. So that's why not 100% of all mammograms are covered at 100%. So when we consider the percentage of insureds that are currently enrolled in those carriers that currently cover it, the marginal impact decreases materially. And we did not get a response from one of the carriers, so this percentage could be even understated, the percentage of members insured by carriers that currently cover it, because we just don't know status in one carrier. Next slide, please. There are some additional issues. These are some of the questions that we were asked to address in our study. And this mandate is not expected to have a significant impact on the cost of the service. We know pretty much what the differences are between the 2D and the 3D, and we don't anticipate the passage of this having a significant upward pressure on the cost of the 3D. It could increase the appropriate use of 3D to the extent that is not currently covered. And it could replace the less expensive mammograms. But I also would have to say that part of that cost could be offset due to the lower rates of recall and the lower number of tests, follow-up tests that have to be done as a result of an abnormal mammogram in the 2D. The scope of our study was not such that we could try to really model that. We're just stating that as an example or a factor. One carrier did have a concern of saying that having to exclude one specific test from a broader benefit category may add to the administrative costs, so we're recognizing that. The total cost of this proposed mandate is minimal because of the extensive coverage currently in place, so it's not going to have a material impact on the total cost of health care. And as the statements before and observations before, given the low cost impact of the proposed mandate, it is unlikely that its passage alone will cause a major shift to self-insurance. Next slide, please. And are there any questions?
Thank you. Questions? Mr. Pollack.
Yeah, I think some of the language in our report here, again, needs to be clear. It's the level 1 evidence supporting this as clearly improved technology is absent. The overwhelming evidence thus far suggests that that's where it's headed, that this is better technology. But I think the lack of a national mandate is because of that, the evidence is behind. And I think it's prudent that we not get ahead of where the evidence is in whatever statements we make. And the fact that this is already overwhelmingly covered really suggests that the need for additional regulatory action is highly limited.
Mr. Thomas and Mr. Moffitt.
Let me ask my colleague, Commissioner Pollack. In the report, I didn't see, nor was it brought up in the presentation, that breast density can vary by different population characteristics. For example, African American women are reported to have more dense, and they suffer from mortality greater than their white counterparts because they show up late. So the question is, and the task force guidelines may not have sufficient numbers of minorities in those clinical trials to make recommendations for them. So it's simply a question with regard to, is it better technology for some? And was the issue of disparities even raised in the analysis? I missed it if it was there.
It wasn't. I actually read a little bit further into the reports that led to the guidelines. So that's not possible to answer that. You'd need better data than what currently exists to be able to answer that. But the disparity issue seems to be related to later presentation, and there's nothing about this mandate that would lead to earlier presentation. So it doesn't seem like this would solve that problem, which is a very, very real problem.
Commissioner Thomas has raised an important point, and that is that disease patterns often vary among racial and ethnic minorities in the United States. And the U.S. Preventative Services Task Force gave very broad recommendations. And of course, in any communication with the state legislature, I think it's our duty to report to them that the evidence on the use of this technology is inconclusive. That has to be stated formally. But Commissioner Thomas raises a very important point. One of the things that I noticed on page 17 of the report, addressing the question of breast density, the authors note, quote, many states have passed state laws requiring providers to notify women if their screening mammograms find dense breast tissue. Rather than a mandate, frankly, given the fact that there is already pretty dramatic coverage in the state of Maryland for this technology, that would be a very sound public policy recommendation to basically say to the state legislature, look, there is very clear division within the medical community about whether or not this treatment is necessary or not. We have these kinds of debates, don't we? on prostate examinations and the use of certain types of diagnostic methodologies like the PSA test and so on. We're very familiar with this. The thing is that according to the report, within the medical profession, and I quote from the report, all consistently, meaning the medical providers, consistently concurred that digital tomosynthesis was medically necessary for screening women with dense breasts. There was less consistency regarding the need for all women to have digital tomosynthesis. If there's a division within the medical profession on something like this, certainly members of the state legislature without medical training should be advised of this, and that should be made very clear in any kind of report. I agree with both my colleagues, Commissioner Pollack and Commissioner Thomas. Both have made, I think, excellent points on this. Those points should be communicated to the state legislature.
So sometimes it's personal. I have dense breasts, I'll just say that. But when I have had a regular 2D mammography, I have almost always been called back for a second time. I've had, it's gone so far as having to have a needle biopsy. And then never mind. This last week, it was time for my mammography, and they offered the 3D. First, checking to see whether my carrier covered it, and they do. So they said, well, it's an option for you. And so I asked, so what's the benefit? And they said, well, you know, it's more accurate, and you know, it's less likely that you'd be called back. And it was, so I chose to do it. It was the first time, frankly, I haven't been called back. And it was, actually, I'm fascinated with stuff like that. So I went over, like, oh, show me, you know, and anyway, I find it interesting. So somebody earlier, I mean, Commissioner Thomas mentioned, particularly on the other bill we were talking about, in terms of this idea came from somewhere. Somebody had a harm. Somebody had a situation where it was necessary and it didn't happen. I think for this particular report, I think it's important not to forget that there is a human impact of being called back. I can't tell you how many weekends I have spent wondering if I have cancer. I mean, my brother died of cancer. I have a sister who had stage 3 colon cancer, and she's alive still. My father died of cancer. So it's a horrible, horrible time that you spend. So all I'm saying is that there's a human impact to this that we can't forget. So one last comment. On the carrier, the 2 carriers ensuring the majority of the market that cover 3D mammograms, I would love to know more about what they've experienced. Have they seen an increase in their costs? Do they see some, especially if they're covering the majority of the market, they probably could break down their data by race or ethnicity or something to give us an idea if there are issues of disparity. So it just might be an interesting follow-up to learn from the Maryland market what the actual cost impact is and whether there is some differences across different race and ethnicity groups.
Thank you, Commissioner Stoneworth, for reminding us of the power of an N of 1. Yeah, Commissioner Sargent.
I'm not going to let you.
I was editorializing, but that's all right.
Does it work? I'm sure I'm not the only. So, and certainly I don't want to denigrate your personal experience, but sometimes the human story is that someone has designed a machine and someone else has taken out financing and someone has bought one, and they really want to drive demand to their new machine. And there are arguments, if you look at who's supporting in here, as to, yes, the science is there. Well, some of them are the people who own the machines, make the machines, and interpret the machines. So I don't want to go too far down the human story. The human stories are very important, but that's not always what's going on. I think what's really important to look at this, and our report does not address it, is the deductible works differently for this mandate than it would for anything else. There's 2 streams right now in an insurance policy. If it's preventive, and the United States Preventive Services Task Force has looked at it and decided the science is there, it gets covered with no deductible payment, no cost sharing, and it's there. And if tomorrow they decide that 3D mammography PCF says the science is now there, it's covered, it goes in. Maryland doesn't have to do anything. Short of that, most of the policies say if it's not preventive, it applies to your deductible, it applies with cost sharing. You have to exhaust your deductible first, and that's how the policy works. Not with this mandate. This mandate says, well, you can apply cost sharing, but you can't apply your deductible. So now you get to write into every policy in the state of Maryland a special rule for this service. It's cost sharing, but no deductible. And then you train the CSR reps on, well, this is how it works. Well, except for this, cost sharing, no deductible for this one. And you get to calculate the difference in price of having to pay for it before the deductibles are met for all the people. And it's, every now and then we'll get somebody, I think, new to the industry usually, and they're like, can we just simplify these policies? Can we just make it simple and consumers understand? And they send them down to my department, the legal department. We have a good laugh with them, and we send them back. This is the kind of thing that makes insurance inscrutable and unnecessarily complex. There's already a mechanism for when the science is there to put this into policy. And I think that, I don't feel like in this thing we address the complexity. It notes it because the carrier said it, but we don't really address what does that complexity do. And it has a cost, both in dollars cost of administering them, but also a cost for consumers understanding what it is they bought and how it works.
Anyone else?
Yeah, I hope everyone's not misled or thinking that 3D mammo eliminates the controversy of dense breasts, because it doesn't. The 3D mammo will not eliminate a dense breast. What you need after that is an ultrasound, and that uses the densities to its advantage. And if you combine 2D mammo with ultrasound, you're going to miss very few breast cancers.
Yeah, I think that the risk here in getting ahead of where the data is on this subject is that to take the N of 1 example of this is that you could wind up with people getting 3D mammograms, misinterpreting them, not getting callbacks more often, and missing more early cancers as a result of the early adoption of this technology. And that's why following the US TTF guidelines on this and waiting for the data to clearly show what's true and what's not is the right answer. Just accumulating more data from within the state of Maryland isn't going to answer the question. We need larger studies from around the country.
Thank you. So with that, let me ask if it's the will of the commission to propose a motion to accept the report as we did before, vote on that, and then characterize the transmittal letter. So do I have a motion to accept the report as it's been presented? Second? Thank you. All in favor? Anyone opposed? Oh, discussion?
A question?
Sure.
So let me know. How do we deal with that administrative cost question, or how have we in the past? I mean,
well, I think it was recognized in the report.
But I don't want to get out ahead of our legislative mandate. Is that supposed to be part of our analysis, and we don't have it, or is it outside of what we were asked to do?
It was. Wasn't it recognized in the report that there was a carrier that made that?
Right.
That
it was
put that
sort of recognized. It's just sort of out there and abstract.
So,
okay.
So what I would say is we'll look at elaborating that further. I think we shouldn't hold up the report, but we would look at clarifying that point in the document that goes to the legislature.
So we've adopted the report, and in terms of characterizing our discussion, I think there was a lot of support for concern in getting ahead of the mounting evidence, recognizing that the U.S. Preventive Services Task Force has ruled this modality inconclusive, but that's subject to change, and that there are both risks and benefits in moving ahead quickly, but to get out of step with the national recommendations would place a particular administrative burden on carriers, should this become a mandate, with not a clear offsetting benefit at this point, and that's to characterize it at this point in time. I think the other point that was brought out by a couple commissioners was the need for special awareness that distinct populations who may or may not be part of clinical trials of significant volume to make mounting evidence. It's an important consideration, particularly with respect to racial and ethnic disparities, as we have experienced here in Maryland with breast cancer mortality and morbidity. And I think that's a really important point to pass along, not only to the legislature, but others, to the U.S. Preventive Services Task Force. Those are a couple of my takeaways. Are there others? Now I'm going to let him speak for himself, or unless you would like to, Commissioner, speak about the administrative burden.
Oh, and I was just going to say for Commissioner Thomas, the USPTF does make recommendations for subpopulations, so it's not my area, but I do believe they look at that when they look at the evidence. But,
Just as feedback, they actually do, and what they say when they don't have the evidence at that level, they say these recommendations are inconclusive for racial and ethnic minority groups. And it has to do with who's participating in clinical trials and a number of things like that. So we do need the data, and we can make that point because it is a serious issue.
Do you have another point to add to the?
no, I think highlighting the administrative point, I don't know if you can explain potential member confusion and stuff. It's really sort of falls into the administrative burden.
All right. Any other comments on that?
I think you did a nice job summarizing the issue about racial and ethnic disparities is important and the impact on women. I mean, I'm just one person here, but I'm sure I'm not the only one. And there is a direct impact on the women who have to get called back. So I would appreciate that being mentioned as well.
Okay. All right. Well, thank you to, we'll let Nova rest then. Thank you very much for your report.
Thank
You're
you.
welcome. Bye now.
Right then, moving on, we have agenda item 5. This is a CON recommendation, and just by way of introduction here, let me give you a brief summary. Recovery Centers of America seeks certificate of need approval for 21 alcohol and substance abuse detoxification or intermediate care facility beds that are regulated by the Commission. You have previously received the recommended decision of Commissioner Randy Sargent, the reviewer for this application, which was contested by 2 interested parties, Ashley Addiction Treatment and Pathways, a subsidiary of Anne Arundel Medical Center. The interested parties did not file exceptions to the recommended decision, so there will not be an exceptions hearing today. Commissioner Sargent will present his recommended decision.
Thank you. And I'll save you time and try to sort of summarize, so if anybody has any questions on the parts of the decision I don't discuss, I'm happy to talk about them. The certificate of need is for 314 Grove Neck Road, OPCO LLC. We want to develop an intermediate care facility for the treatment of alcohol and drug abuse. It's a 530-acre site in Earlville in Cecil County, or Suffolk County. The applicant is owned by Recovery Centers of America Holdings LLC, or RCA, so we'll call it RCA Earlville. They're a new entrant into addiction treatment services here. They have two other pending applications that are on a different schedule. Hopefully we can move them along.
Commissioner, could you pull the microphone over?
Shortly. I wonder if it's not. Is this one better? All right. Is that better? All right. So RCA is a new entrant in this area in Maryland. It has 2 other pending CON applications, which hopefully will follow along shortly in January 2017. The short phrase is, having considered the record in the review, I recommend that they approve the application as modified in its most recent filing. They are, as modified, there's a schedule they originally filed in March 2015 and they refiled, but the last version, they want a facility that will have 21 beds classified under ASAM, the American Society of Addiction Medicine, level 3, 7D, medically monitored inpatient detoxification. Only detoxification and treatment services provided at the inpatient level of care are regulated as ICF by us. So only the 21 bed detoxification part of their service will require a CON. They've gotten a determination of non-coverage for 87 level 3-5 clinically managed high-intensity residential treatment beds that do not require CON approval. So the facility itself, 21 beds that need a CON, 87 beds that don't. The total project cost estimate is $32,581,335 with $5,595,384 for the total as the cost of the CON portion. The project costs are anticipated to come from equity funding of $4.5 million and a mortgage loan of $28 million. Deerfield Management Company is providing the senior debt for the entire project. The Ashley Inc. DBA Ashley Addiction Treatment, previously known as Father Martin's and Anne Arundel General Treatment Services, also known as Pathway, sought and were granted interested party status and raised a couple of issues that are part of my recommended decision. In terms of background, they filed the CON application in March 27, 2015. Then they filed the modified application on May 18th of 2015. In July 15th, 2015, they requested determination to proceed with the non-regulated beds and got a determination of non-coverage at that time for those unregulated beds. The modified application was docketed on October 16th, 2015, and Ashley and Pathways filed their comments seeking interested party status, which were granted. In December 21, 2015, they filed a corrected modified application to change the number of beds. In June 2016, they filed the notice that the cost of the project would be increasing due to some design changes they had made to comply with fire code. And because of the increase, they updated the application to reflect the increased costs and submitted revised information in July 28th of 2016. I held a status conference in September 20, 2016 at their request and made some preliminary findings about the charity care obligation at that time and some requests for updated project drawings and other things. They filed their amended filing application on October 7th, and that's the one that we're approving today. So I know we've had some discussion about length of time for CONs and things like that. This might not be the application to get too far into that because there have been a number of amendments and changes as the filing process went through. It's my recommendation that the Commission approve with conditions their application as modified in October. It's based on my findings that the project is consistent with the applicable state health plan standards and the certificate of need review criteria in COMAR. My decision goes through each of the applicable regulations and how it complies. I wasn't planning to do that to you here because I like you all. But I'm happy to discuss any of them about which you have questions. I thought what I'd do is tell you, though, the 3 points raised by the interveners and the results of those. Basically, the intervening parties focused on whether there was a need for additional detoxification beds, whether the project would unduly harm the interveners or other providers of similar services, and how the requirements for the indigent and gray area patients should apply to this project. On the first one, I concluded the applicant has demonstrated that the project is needed based on the bed need analysis in the state health plan chapter for alcoholism and drug abuse, intermediate care facility treatment services. RCA Earlville also made a showing that the project is viable and a cost-effective alternative for meeting that need, largely on similar evidence. There's a growing consensus, in my view, that additional resources are needed to battle substance abuse and addiction, which has emerged as a critical public health issue in recent years because of the sharp increase in drug overdose deaths that have occurred in Maryland and throughout the nation. With the assistance of staff, we did make some adjustments to the numbers submitted by RCA Earlville. They had focused on private pay rather than the whole market, but it was largely a wash by the time you expanded the analysis on all sides. You came out to about the same place. The second one issue, I concluded the facility's impact on existing providers will not be overly adverse or beyond the scope of what can be expected to occur in a normally competitive market. The proposed project is a track one facility that is predominantly aimed at serving insured and private paying consumers. There may be some competition for patients or to retain staff, but I saw no evidence that I thought would justify the exclusion of RCA Earlville from the marketplace. Competition is to be expected and encouraged in such a situation. The primary impact of this project will be positive. It will improve access to this type of inpatient treatment, including more availability and accessibility to the lower income population. In getting to that, finally, RCA Earlville asked for a modification of the charity care standards. COMAR 10.24.14.05D governs the provision of care to indigent and gray area patients. Under that standard, an applicant normally must commit that it will provide 15% or more of its proposed annual adult ICF bed days to going on here, of course, is there is no such requirement for the 87 rehab beds. This is only the 28 detox beds. RCA Earlville came in and made a showing that it would actually be a better course of treatment to let someone come in, go through the detox therapy, go to the rehabilitation therapy, and do the full course at the facility. If they provide the full 15% bed days in the detox areas, then also folks will either need to pay to stay or they'll need to go find a different facility. So what they proposed was to, instead of providing the 15% of detox bed days, they would provide 15% of an equivalent amount in their revenue, and they would provide it in both types of beds. So we did two things. We converted from a bed day standard to a revenue standard, expressing the value of the detox bed day, and then they can provide those services by allowing the folks to stay the whole time through both services instead of having to move. The reason it's converted from bed days to revenue is that the detox beds are more expensive. So if you just continue to count bed days, it would actually be less charity care provided. So we say you have to provide the same revenue you would provide in charity care that you would provide if you met the bed day standards for detox beds. But you could spread it across the full treatment or provide the full treatment to individuals. And I thought that was more in the interest of the folks who were receiving the treatment and then making sure that the treatment was effective. There are 5 proposed conditions, all of which have been accepted by RCA Earlville. The conditions are that before they first use approval, they must receive preliminary accreditation by the Joint Commission and timely receive final accreditation. Prior to first use approval, they have to provide executed transfer and referral agreements with some providers that they don't have them for yet that are called out in the decision. Before first use approval, they have to document additional referral agreements with sources likely to refer indigent or gray area populations consistent with the regulations. And a requirement that they would provide us, the fourth one is that for their charity care commitment, they'll provide us with a report for the next 5 years, basically an annual report showing that they've met the standards that we're imposing. And finally, the fifth condition is one that is similar to what Ashley had when we approved it, that at the end of the 5th year of full operation and following completion of their project, they'll provide a report to the Commission on its program effectiveness using measures drawn from recognized organizations that develop and promote the use of quality measures from other sources approved by the Commission staff. So the gist is they'll come back within 5 years and report on the effectiveness of the program, similar to what was required of Ashley. That was it.
Yeah. Sergeant, for your report.
And I apologize. I should have done right up front. I wanted to thank staff for their work on this. It was tremendous.
I will entertain a motion and a discussion on the recommended approval of the CON request. But before I do that, I'd like to recognize some of the representatives of the applicants who are here so that commissioners know that these people are here in terms of maybe thinking through your questions. With us are JP Christian, if you just identify yourself, Chief Operating Officer. Dr. Denny Caris, Chief Clinical Officer, Adjunct Professor, University of Pennsylvania School of Medicine. And Dr. Barbara Christenmacher, CEO, Bracebridge Hall, Earlville. Did I get that right? All right. Thank you. So with that, may I have a motion on the floor, and then we'll carry forth with some discussion. Motion for approval. Thank you. And second. Thank you. Discussion, question. Oh, let's receive the microphone. Questions for Commissioner Sargent on recommendation. Or of the folks here from, I say Cecil County. I guess it's Cecil County. Oh, Cecil County. All right. Just a comment. I thought that the approach to amending the charity care standard from bed days to revenues was not only innovative, but it's in line with holistic treatment of people, and makes sense certainly from a clinical and it sounds like from an administrative point of view. And to commend you because it sounds like that's a greater commitment in terms of dollar value of treatment than otherwise would have been the case. So I thought that was particularly notable. Any other comments or questions before we proceed with a vote on the application? Hearing none, then all in favor of approving the CON as outlined with the conditions as outlined by Commissioner Sargent, please say aye.
Aye.
Anyone opposed? No opposed. The CON is granted. Congratulations. Oh, I'm sorry. You've driven all the way down here and you didn't get a chance to speak. So please let me bring you up to the microphone and give us your comments. Thank you. Please sit down and introduce yourselves again, if you would, for the record.
Turn on the microphone.
Green, we're good.
Thank you, Commissioners. I'm Ella Aiken, and together with my colleague Tom James, we represent Recovery Centers of America and the applicant in this review. And just as a reminder, this is J.P. Kristen, who's the Chief Operating Officer of RCA.
We would just like to thank the Maryland Healthcare Commission for granting our CON today. We'd like to thank Commissioner Sargent for acting as reviewer. And we'd like to thank staff for the careful review of our application. And we look forward to being here again next month to review our other two applications. Thank you.
Thank you. We look forward to seeing you. Ben?
So I wanted to thank RCA for their application and note, I think 2 meetings ago we talked about approaches to allowing innovators into the Maryland market who have been offered services previously. I'm sure that they would say it's been at times challenging, but we did bring this application through for your review. You'll clearly there is a two-tiered model in Maryland where we have a public model and a private side. What's happening is there's a hopeful sign in that the state's new 1115 proposal will include an option to include long-term rehab for Medicaid beneficiaries. That has not been something Medicaid has been able to offer. It's too early to say whether CMS would accept that. The 1115 waiver, new 1115 waiver, has not been even submitted at this point. It will be in 2017. Naturally, RCA's we will make certain that you're advised of when that happens, and there hopefully would be a way that you could participate. Obviously, it's too early to say right now whether it will be approved and whether it would be something that would represent an opportunity to you, but it does indicate, I think, greater flexibility on the part of the Medicaid program to participate in these longer-term rehab programs that heretofore they've been resistant to engage in. So thank you very much.
Okay, then moving to our next item, also a CON proposal, and I guess I'll invite Kevin McDonald to come up. This is an application by Maryland House Detox, Delphi Behavioral Health Group, and DCX Group, which will do business in Maryland as Maryland House Detox. Submitted a certificate of need application to establish a new intermediate care facility that will contain only detoxification beds in Lincecum, that's in Anne Arundel County. And Kevin will present the staff recommendation on this application.
Thank you and good afternoon. Again, the applicant is Maryland House Detox. It's a proprietary corporation. It's co-owned by Delphi Behavioral Health Group and the DCX Group. Delphi currently owns and operates 8 facilities that provide addiction treatment and a variety of treatment programs at 5 locations in Florida and 3 in California. It's a 16-bed unit. It's detox only. I think they're looking at an estimated length of stay between 5 and 6 days. The project would cost about $1.1 million in capital, and there's also $740,000 of working capital in the budget to cover startup and carrying costs, and the project would be funded entirely in cash. Looking at the project through the lens of the state health plan and our criteria, I'll highlight a few of those more cogent critical items. First of all, need for the program. The need in the state health plan projects a need in the Central American, Southern Maryland region of, I know that's Central Maryland, 113 to 160 beds. So the 16-bed detox is well within that parameter. In terms of service to the gray area population, the applicant has agreed to meet that requirement, and that will be one of the conditions. Reporting of that will be one of the conditions that we're recommending in the CON approval. They are proposing to do that by operationalize that by earmarking 2 of the 16 beds, basically on an ongoing basis for that population, and to monitoring the bed days so that they are going to meet the 15%. In terms of transfer and referral agreements, they have a strong list of providers across the treatment spectrum, as well as referral agreements with organizations that would be expected to serve gray area population and thus be likely to make referrals of that population to Maryland House Detox. They've expressed a willingness and interest in measuring effectiveness and offered to share data with the state and evaluate toward the end of any studies the state wants to do on that, as well as evaluating their own effectiveness. In terms of the cost effectiveness of the project, the applicant posits that its sole focus on detox as an alternative to the more traditional 30-day program, and they're not by any means downgrading the importance of the 30-day, just making the point that there's a role for both. What they spoke to is seeing their program as offering the flexibility to refer a patient after detox to subsequent lower levels of care if that's appropriate for that particular patient, such as a day program, partial hospitalization, or an outpatient program. The viability and financial feasibility, again, the resources are there to implement the project, and the projections show a positive bottom line going forward. In terms of impact on other providers and the health care system, staff concludes that given the large projected need for this service and the fact that this is only 16 beds, that it is very unlikely that there would be a negative impact on any other providers, and in fact there may be some synergy with some of the long-term programs of having this gateway into the treatment process. In summary, staff finds that the project complies with the applicable standards in the state health plan, is in accordance with the certificate of need criteria, showing to be needed, viable, cost-effective, and a project that would likely have a positive impact on cost to the healthcare system, as well as significantly, or not significantly, but certainly added public access to that service. The staff does recommend approval of the project with a couple of conditions. One is that before first use, Maryland House receives preliminary accreditation by the Joint Commission, and that they provide an annual report on their performance on the gray area obligation. We do have representatives here with us today, and that is David Stoops, the CEO of Maryland House, Cynthia Curtis, who was the Chief Operating Officer, and Jackie Arthur, who was their regulatory consultant.
Thank you, Kevin, for your report and for your hard work on bringing this forward to us today. May I have a motion to approve the CON? We'll have some discussion. Thank you. Second. Thank you. Questions of Kevin or the applicant? Mr. Khan?
I just want to know if the organization, what's their benchmark for success? It almost sounds like a triage unit where, I mean, do these patients have 6 days, is it said? 5 days? How many days? 6 days of treatment?
Between 5 and 6 days.
Between 5 and 6 days. These.
We could invite the CEO to come forward.
Yeah. Are there, what's the proportion of these patients that actually go home? Or do they all go to another higher level of care? So basically, you'd be a triage center.
Exactly. So our measure of success would be the continuation of treatment in some form or another, whether it be a residential level of care, a partial hospitalization level of care, intensive outpatient level of care, or outpatient level of care after the subsequent crisis intervention. Our average length of stay that we projected is based on our experience for insurance authorization, right? In a perfect world, in our world, we would like to see people longer than 5 to 7 days. It's been our experience that 5 to 7 days seems to be the typical insurance authorization now with acuity of patients or comorbidities. We may get longer authorizations, and the fact is that we may perform a longer length of stay past an insurance authorization as needed. So our measure of success would be the continuation of treatment, essentially the entry into the treatment system, the existing treatment system here in America.
And your acute treatment protocol includes medication, I assume?
Yes, medically monitored inpatient detoxification.
Is it monitored by psychiatrists or?
By psychiatrists, medical doctors, nurse practitioners, and
Thank you.
Just to follow up on that, how do you monitor discharged patients for their retention in treatment?
So we have a system within our electronic health record that allows us to set reminders for each patient that's discharged, essentially. Set reminders, and then we have releases signed prior to admission that allows us to follow up with these patients.
With the patient or with the provider?
Patient and the provider, right? So what we'll do is we'll follow up with the patient upon discharge. We also follow up with the provider upon discharge to essentially find out if they're engaged in treatment, if they made their initial contact, and then we do plan on following up for a period of time, up to 12 months after that, find out how their subsequent treatment went.
And does that data roll up someplace to the State Behavioral Health Administration?
It does not. That would be solely done voluntarily. The reporting system that's in place now for substance use providers is only mandated through the public side.
Oh, I see. So private patients you're not required to report on the outcomes of private patients.
We're not required to, and just saying that we're not required to doesn't mean that we don't want to. But there is no standard system in the state of Maryland to do so.
Mine's not so much a question, but more an observation and comment to the commission. I see these certificate of needs for treatment centers, and I think it's a valuable part of the entire continuum of care for this type of problem. But it seems to be in our country, and of course in our state, and I'm from Allegheny County, and we're just being destroyed by substance abuse right now. With, like, in the little county I'm from, with almost 400 overdoses this year, is just unprecedented. And it's in our schools. It's just everywhere in our society. My wife teaches. She's had 3 or 4 or 5 children in her class who've actually witnessed parents overdose. Some of them survived and some of them have not. How do you repair that child? I guess my observation is I hope, and I know that the governor, and I know that at the federal level we started to take a look at some of the prevention and education efforts for this. But this is the last stage. This is the, you know, I always tell my children that if you get involved in substance abuse, you're going one of three places. You're either going to jail, you're going to rehab, or you're going in the ground. This is one of those three places. I applaud the effort, you guys, and what you're doing to try to help folks that are in this situation. But I hope that we as a commission and as a society are coming up to speed to recognize that maybe we should be pouring some of our resources at the front end of this problem, where at the back end of the problem, it's almost too late, and there's consequences. There's already consequences for those folks. It's very expensive to treat. The damage is done to families. Families are broken. Children have seen things. People have died. People have went to prison. So I just want to make that observation, because I'm just as Diane said, you see it on haven't had it in my family, thank God, but you see it on a very personal level, right in your community with people you grew up with, and I think it's a state and national problem that can't be addressed soon enough.
If I may. So I salute you. It's a very, very tough problem, okay? Say something about the wait time. Let's say someone needs to get into a facility because they're in the emergency room. What's the wait time to get into your facility?
So we actually
bring that mic real close. We're being recorded here.
We have actually begun preliminary talks with and throughout our application with Baltimore Washington Medical Center, which is the closest acute care hospital to our facility, to create some type of memorandum of understanding to transport directly from the emergency room to our facility. Have the ability for the emergency room to possibly begin treatment in the form of some type of medication stabilization, and then transport to our facility. So,
so that's an MOU that's not currently in place?
It is not yet. We don't have a certificate. We didn't have a certificate. I need to proceed with that, but that is something that we would like to expand, not only with Baltimore Washington Medical Center, but also with as many hospitals in the state as possible. As far as wait times are concerned, I do not have a projection for you, and I cannot. I don't want to sit here and try to give you a projection and tell you that everybody that calls that we're going to have an open bed.
Just from experience.
So,
in your other locations.
So our other locations, we actually operate the 3.7 level, which is this level, all the way down through outpatient, right? So we offer same-day admission most of the time, and if it were in a perfect world, we would offer same-day admissions here. I do believe that for most of the beds, we will be able to offer same-day admission. For the charity care, I do not know if, I believe that there will be an extreme demand on that charity care, and I don't know if the charity care, we will be able to offer same-day admissions, but they will be given the same priority as the privately paying patients.
Thank you.
I just have a question of clarification, and I'm not sure if this goes to staff or you, sir, and that is the reference about the fact that there could be a wait as long as 28 days to get into an open bed. And if this is a detox-only approach, are there sufficient beds for once someone has gone through detox to get them into the treatment that they need? Or is there a lag time between the detox and the treatment, which kind of creates a revolving door of detox then, if they're not able to get into treatment?
I'll answer that.
Thank you.
So, two parts of that question. We view ourselves as a completely unbiased decision maker on the next level of care. So, for some patients, that next level of care may not be a 3.5 level right? So we will be solely guided by the ASAM placement, patient placement criteria that will determine which level of care the patient will go into. So that is the first part that I'd like to answer. The second part of that question is that if you turn to page 13 of the report, we have actually executed transfer and referral agreements with a number of programs, and these programs represent essentially every level of care for substance use treatment, and multiple providers for each level of care in the state. And this is anecdotal knowledge, and from my experience in working in the state and working in the industry, and especially working with organizations who are interested in entering Maryland, and organizations that have entered Maryland to provide a residential level of care down, which is the 3.5 down, that is not subject to the certificate of need. Over the past 5 years, obviously, there's been an explosion of demand for substance use treatment services. So what we've seen is a proliferation of providers offering a 3.5 level down because of the nature of the certificate of need process in Maryland. And I say that independent. Obviously, our experience was that we wanted to provide this level of care, but what we've seen is a number of providers entering the state and only providing a 3.5 level down rather than the 3.7 level down. So not only do we have the ability to refer those patients to a bed if they need to have the 3.5 level down, but we also view ourselves able to serve patients that may be seeking those treatment services.
So do you feel that there is sufficient, and maybe this is a question for staff, is there sufficient capacity so that a patient who has gone through detox isn't in a holding pattern waiting to get into treatment? I understand the variety of relationships that you have in place, but that doesn't speak to whether the beds are full or there's capacity for the treatment separate from detox.
I don't think we can speak to that at this point in time.
So if someone has gone through detox but there's no open beds available, they might end up back in detox.
Well, it is our goal that 100% of our patients are referred to the highest level of care possible upon discharge. So our goal is not to create a revolving detox door. Our goal is to refer to the highest level of care possible within that patient.
Referral is different than actually getting into care, right? Or am I missing something? I mean, you can get a referral, but it doesn't necessarily mean that there's actually a bed, treatment service available.
Right. So we've actually written protocols that we will provide transportation, and we will also invite the accepting provider to do a face-to-face consult with our patients in our facility prior to discharge. So those are the types of warm transfers that we talk about in our application that not only do we recommend, but that we're going to institute in order to strengthen that referral relationship so that they actually make it to the next level of care.
I'm not sure if I missed this during Kevin's presentation, but approximately what do you expect your breakdown to be between those suffering from alcohol addiction and those who are addicted to narcotics, for instance?
So I can tell you anecdotally speaking, throughout our experience with Delphi Health Group, is that it's actually somewhere around 40% of alcoholism, and then the rest is some other type of illicit substance.
And you're fully equipped to handle all the physical ramifications of the withdrawal syndromes that develop.
Correct.
which brings the people through to the point where you can begin to communicate with them about follow-up care and
Correct.
further therapy.
Correct.
Thank you. I used to work in the field, so I detox and rehab for 3 years, so I know it a little.
When the patient finishes your program, the 5 or 6 day program, and they need to go to a higher level of care, say a 21 or 28 day program, do they get credit for that 5 or 6 days and decrease cost of the overall system, or are you an added cost to another, and they go through another 28 or 21 day program? Do they get credit for your 5 or 6 days in the acute detox, and then go to a detox center, but don't have to go through the same whole protocol again for 21 days or 28 days?
Correct. So the subsequent level of care, it is a residential or a partial hospitalization or intensive outpatient level of care. So we're not adding costs to the system. Again, there are providers out there, and a large number of providers in Maryland, that are providing everything except for the detox level of care. So oftentimes the patient's entry into the treatment system begins at detox. And what we want to do is provide that entry into the treatment system for patients who may not have entered the treatment system if they couldn't make it into a detox bed in the state.
Okay, unless there are other questions, then we'll go ahead and have a vote on the motion that's on the floor, which is to approve staff recommendation to approve the Maryland House detox application for certificate of need. All in favor?
Aye.
Anyone opposed? No. Motion carries. That is CON. Congratulations.
Thank you. And I want to thank Kevin and his staff for the constant work and communication with us, and thank the Commission for an open line of communication throughout this process.
Well, I appreciate you saying that, and I also was attentive to your comment that there was maybe a dearth of providers willing to step forward and to go to the highest level, which you have done for detox, for a lot of reasons. One of which was that was the threshold. You crossed the threshold to go through the CON process, and so I picked up on that, and I commend you for doing that, because I'm sure there is definitely a need. There's absolutely a need for your service.
Thank you.
Don't go away. All right, let's shift gears a little bit, not too far away from Kevin, to the next agenda item, which is also certificate of need. We're going out of state now to the Massachusetts Surgery Center. Massachusetts Avenue Surgery Center applied for a certificate of need to convert an existing non-sterile procedure room to a fourth operating room. Mr. McDonald will present the staff recommendation.
Thank you. So the applicant is Massachusetts Avenue Surgery Center, LLC. They were established in 2004 as a physician outpatient surgery center, a one-room POSC, which does not require a CON, but did require a determination regarding the CON process. They subsequently expanded through CONs in 2006 and 2012, adding an OR each time. The application today is to convert a procedure room into an OR. Over their lifetime, over the 12 years of operation, they've grown from an initial 14 surgeons to, at this point, 54 surgeons with privileges there, which is part of the driver of this application, why they're here today. Their volumes have been steadily rising, about 5% a year for the last couple of years. But the real catalyst, I believe, is the fact that they have recently added total joint replacement surgeries to their offerings, and that has those procedures have a dramatically higher OR time, and has put a strain on their system. The total cost of the project is estimated at about $266,000. It will be funded in cash and is anticipated to take about 5 months to complete. In terms of justifying the need for the project, according to our state health plan standard, the applicant must demonstrate that it has been operating at optimal capacity for at least the last 12 months, and that it projects to do so at its new size within 3 years. optimal capacity is defined as 80% of full capacity. Full capacity is 255 days a year, 8 hours a day. So based on the OR time that they project, adding in the turnover time, that's how we look at the need justification. The facility exceeded that benchmark in 2015, and year-to-date 2016 projects to do that again, so it meets that portion of the standards. And with the projections, it projects to do so within 3 years, so it does pass that standard. In terms of looking at it from a cost-effectiveness perspective, I think one of the key things it does is that it makes better use of surgeon time than having to, the alternative of perhaps not doing this and surgeons going other places to do their work and spending time in the car rather than the OR. So from that perspective, it certainly seems to be cost effective. Viability, resources are clearly available to implement the project, and both the current operations and projected operations show a positive bottom line. Impact does not project to impact other facilities. It projects fairly modest growth, which really is based solely on its existing market share, which would be augmented by population growth. And consumers and payers should benefit from expanding this lower cost surgery setting. So in summary, staff believes that the project complies with the applicable standards in our state health plan, the General Surgical Services chapter, and it is in accordance with the Certificate of Need review criteria, showing to be needed, viable, a cost-effective alternative to meeting project objectives, a project with positive impact on the cost to the healthcare delivery system, and coming from an applicant that has a sound track record with 2 previous CONs. Therefore, staff recommends the project for approval, and we do have 2 representatives of the surgery center here, Randy Gross, who is the executive director, and Andy Solberg, who was their CON consultant.
Dan, for your report and the work behind it. Motion to entertain, motion to approve. Second. Discussion? Questions? I have a question about this phenomenon of total joint replacements in outpatient settings. Can you talk about that? So the projection is 70, oh no, it's a projection, 75, in the current year, 75 such cases. So is this the tip of the iceberg? Is this the leading edge of where we're going in terms of what we're going to see now?
To repeat an analogy I've used before, if you cross the border into the United States, you find that happening very frequently. Innovative.
Well, this is Massachusetts, right? No.
Innovative programs like that, which dramatically decrease the cost of joint replacement and have been shown to improve patient satisfaction with outcomes, are possible in the context of lower regulation. It's very difficult to do that in the state of Maryland, and I applaud the applicants for moving in that direction. I can tell you that the payers are going to be opposed in general to paying for joint, at least they have been in this area of the state, maybe not there. But what we have heard from the payers is that if we do that, if we give you rates on joints that are half of what they are in the hospital, but nonetheless more than the regular ambulatory surgery costs, in other words, to cover the cost of the implant, then what will happen is you'll move the joints out of the hospital and into the ambulatory surgery center, and we'll pay for them in the ambulatory surgery center, and then we're going to pay for them again because the hospital rates will go up to offset
that's a different problem.
to offset the lost volume.
We're not going to go into that.
It's a GBR problem that prevents this type of innovation from occurring on a more regular basis in the state of Maryland. And I think it's important to recognize that when it happens. But I congratulate you on the project.
Thank you, Commissioner Pollak. Other questions? Ben?
On that note, I do believe that the Largo facility of Kaiser Permanente today is doing total joints in their ambulatory surgery center at the payer office. Yes, it is at the payer.
Okay, other comments, questions before we have a vote? All those in favor of the Massachusetts Avenue Surgery Center's application for certificate of need, say aye. Aye. Opposed? Motion carries, and your certificate is granted. Congratulations. Great. Great to hear from you. Okay, well, down to the end point here. Getting down to the end of the year, the end of the agenda, and we've got item 8, proposed user fee assessment. I'm going to invite Bridget Zombro, Director of Administration, and Denise Ridgely, Program Manager, to come forward as we hear the report and proposed regulations. So it's an action item on the agenda, twofold: to approve a report and to look at proposed regulations. By way of background, every 4 years, the Commission performs a workload study to determine how the Commission's total assessment will be allocated among payers, hospitals, nursing homes, and licensed health professionals. Bridget and Denise will present the study as well as draft amendments to existing regs that staff will request to be adopted as proposed permanent regulations.
Thank you. In addition to the study for the workload every 4 years, we're also required to adopt regulations that permit a waiver to this fee for the health occupation board that earn an average annual wage that's substantially lower than what we calculate that to be. With the passage of House Bill 800, it raised the Commission's user fee cap to $12 million. It also asked us to, I'm sorry, I have to really bad cold, to study to the extent possible what other healthcare providers could be brought into the user fee assessment and discuss the feasibility of extending a user fee to those types of providers. And most recently, recommendations from the fiscal year 2014 preliminary sunset review asked the Commission to explore the possibility of how the workload distribution might, at least in part, consider future workload requirements. The last time we did the study, we actually looked retrospectively instead of looking prospectively. The assessment and how it's calculated, each entity has a different methodology that we use to calculate their fee. Health insurance companies are based on a ratio of total earned premium collected for the health benefit plan over all total collected earned premium for all payers in the state. Currently, we assess about 68 insurance companies. Nursing home and hospitals, they have the same type of assessment. After their assessment is calculated by admissions for the facility over total admissions in the state versus total gross revenue per facility over all revenue in the state. Currently, we assess about 230 nursing homes and about 46 hospitals. The health occupation boards are done a little bit differently. It's just a flat fee spread over all the licensure categories in the state. Right now, we assess probably about 150,000 licensees.
The current allocations of the user fee are payers at 28%, nursing homes at 17%, hospitals 33%, and the health occupational boards at 22%. As in the previous slide, this assessment is derived differently for each entity.
On the next slide, as the recommendation in the sunset required us to do, we use fiscal year 17 as sort of our benchmark. And then because I had already prepared the 18 budget, we looked at what fiscal year 18 will bring us, and we just did a 5% inflation factor over that for FY19. If you look, our budget can change quite drastically sometimes in this allocation. If you look at FY17, I wanted to point this out to the Commission, and break down the how I would apportion the FY17 budget now, it would be payers about 25%. We're currently assessing payers 28%. So I wanted to show you how that can, adjust from year to year. So it's hard when you're doing a 4-year study. And then again, we looked ahead at fiscal year 18 and 19. Because we just did a 5% inflation factor between the 2 years budget, you can see that the assessment remains the same between those 2 years.
So we did use an average between 17, 18, and 19, and the new allocations would be payers at 26%, nursing homes at 19%, hospitals at 39%, and the health occupation boards at 16%. The next part of the study is the background of how we calculate the average annual wage or hourly wage. Each health occupation board report each category of licensure. We use the state personnel classification system to break down each one of those classes of a health occupation. We match all categories of healthcare practitioners to the state salary scale for their compensation from highest to lowest. We do that to keep the average annual wage at reasonable. We also want to note that the average that we calculate is not to be used as a reflection of salaries all through the industries as a whole. But we use this because it's consistent, it's transparent, the health occupation boards have access to what we use, so that's why we continually use it. When we calculate that average, those that are familiar with state categories, it could be occupational therapist 1, 2, 3. We only actually use the salary for 1 to keep it fair. The list of the healthcare practitioners that are currently assessed, the board, are listed there. There are no additions to this list. The current average annual wage is $36,280, or equivalent to a grade 14 on the standard salary scale. Going through, I don't know how many classifications we looked at, we were kind of happy to see that the new average annual wage kind of corresponds with that grade 14 on the salary scale, but is now $38,629. So there are no new exemptions to the fee. The board and classifications that are excluded from the fee are listed right on your page. The next thing that the report asks us to look at is the inclusion of additional healthcare providers. So we broke down where we spend money on ambulatory surgery. We looked at hospice, and we looked at home health. And each one of those dollars are affiliated that we spend in FY17, 18, 19. They are not going to be included as AMSURG is about 1% of our budget currently. Hospice providers are what we're spending on right now. It's actually less than 1%. And home health agencies are also about 1%. The commission statutory cap increase. Currently, we cannot assess over $12 million, but we can bring additional funding into the commission as long as we're not assessing it. The commission is currently appropriated at $15 million. However, we only assess the industry based on 12. So there's a $3 million hole. The last statutory cap increase for the commission was in fiscal year 2008. The key drivers in the last 5 years contributing to our increase in budget is patient-centered medical home project, the expansion of the APCD, reporting on hospital and HMO quality and performance, and health information technology. DLS, Department of Legislative Services, recommended in their final report of the 3 health regulatory commissions for their sunset review
to increase the cap for both the MHCC and the HFCRC. If we were to get that cap increase, and that slide outlines what the pathway would be for each of the industries with the new apportionment based on our FY 2018 budget of 14.5, payers would pay about 3.7, nursing homes 2.7, hospitals 5.6, and the health occupation boards about 2.3 million. I broke that down and went down and figured out what the fee would be to the health occupation board. And based on 14.5 million, it would be $15 for an annual license or $30 for a biannual license. Saving the health occupation board is about $6 for a license renewal cycle. Staff recommendations are we ask that you approve the release of the user fee report, and I request your approval to amend COMAR 102502 and COMAR 102503 and adopt them as proposed regulations. We also recommend continuing to study the feasibility of assessing other healthcare providers in the future. And finally, we concur with the Department of Legislative Services to increase the user fee cap. This concludes our presentation. I'd be happy to answer any questions for you.
Thank you, Bridget. Great job, as always. You break it all down so neat and clean, and that's like just the numbers. So there's a lot of numbers here, very interesting ones. So could we get a motion to do both things, to approve the report as well as to approve the proposed regulations, and then we'll go forward with discussion? Thank you. Thank you. Comments or questions, Bridget?
I'm sorry, I'm sure you're tired of hearing from me today, but on page, well, you don't have pages numbered, but on the summary of allocations of cost page, it has listed under payer-specific costs the HIE, which actually shows up under nursing homes and health occupation boards, but not hospitals. So I was just wondering what HIE costs are getting assessed to payers, and why are hospitals skating on them?
Are you speaking of in the report?
Yeah, it's in their slide deck.
No, no slide deck. I'm sorry. Oh, okay. Sorry.
Looks like page 6.
The summary of allocation.
Yes. Yep. And if you look under payers, it has HIE for Health Information Exchange, I'm assuming, which doesn't show up for the hospitals, but shows up for everybody else. And I was just wondering, I don't know that the payers do much with the HIE, what those costs are.
Actually, it probably was included, and if I could take a second and look in the report, I can tell you the allocation in the back. Actually, Commissioner, it is in the summary of the report itself. It is listed at about between 25 and 35%. I just did not outline it here on the slide deck.
Page 4 of 7 of the spreadsheet.
I guess what I mean is, what are the costs that are attributed to the payers? Why are the particular items attributed to the payers? It seems to me that HIE is primarily something that is a provider benefit. And hospitals are not paying for the HIE, which seems odd to me because hospitals use the HIE a lot. Does that make sense?
Yes. Okay. I would say that largely the hospital-specific costs under the different cycles of the budget with the HIE, a lot of that.
David, if I could ask David Sharp to come on as well in terms of all things HIE.
Yeah, it's really a broader question than the number. Is who decided who should pay for the HIE and in what amounts and why? Does that make sense?
That's a good question. Think of HIE in general sort of like the ocean. It raises all boats. The water raises everyone equally. HIE diffusion allocation of the infrastructure, the build out, the assuring the gateways work, the API development. Even though your big consumers of the data tend to be providers, the publishers, it requires just as much on the infrastructure build and just as much commitment to maintaining that infrastructure build. So it isn't we just pay by the consumer of it. You have to build it and then sustain it as well.
Okay, so how did we get to the numbers then? And was it an allocation of particular items or a global, this seems fair? I don't want to characterize it in a way that sounds like I'm being pejorative. How did you get to the particular percentage?
You want to go ahead?
Labor costs, and what the staff works for, and any project that we contract out for.
Well, you're like sort of this one goes to the payers and that one goes to the hospitals, or
Some
more of a global?
Yes, some of them are very specific where you can do that. Others we kind of spread by percentage and share over all the industry.
Okay.
A share of staff resources, if you will, project time.
And I may have missed on the chart. It doesn't say the hospitals on the slide. Are we allocating some of the HIT?
35%.
Okay.
It's in the report. Yeah. I'm sorry, I didn't put that on.
Page 4 of 7.
Thank you.
Page 4 of 7. If you look.
That's the one with like 6-point font numbers.
Yeah,
I saw that page.
Other questions, comments? Or David? If I heard you say this correctly, this reallocation, Bridget, will result in savings of about $6 a year to 150,000 licensees by the workload study and reallocating the cost.
Correct.
And that includes an increase in the cap. Yeah.
Right. Because without that increase to the cap, I can only assess them at $12 million. They're currently being assessed then, but I would say that dropping their apportionment of the budget from 22 to 16 would definitely be similar. But if we do get a cap increase for fiscal year 18, our budget's 14.5. If we would get that increase, the payers would save $6 a license.
The licensees would
say the licensees. I'm sorry, licensees. Right.
Thank you. So at this point, other questions?
But just probably allow me to say that the whole tax is the consumer direct.
You want to answer that, Dave? You can't argue with that. You have a rebuttal to that?
I would say correct.
Okay. Thank you. With that, let's have a vote. All in favor of both adopting the report as well as the proposed regulations, please say aye.
Aye.
Opposed? Recused. Mr. Metz, so noted. Thank you. No opposed? So both motions carry, or the combined motion carries. Thank you very much for your work. David, don't go away. I think you're up. Oh, okay. Oh, sure. Okay. Just see. Right. So, but it has to do with HIT. It's the grant award, Improving Patient Outcomes Using mHealth Technology. So Justine Springer, Program Manager for the Center for Health Information Technology and Innovative Care Delivery, will present on the Mobile Health, known as mHealth Grant Award. Joining Justine is Susan Huff, RN MSN Director of Johns Hopkins Pediatrics at Home. If the grant is approved, Ms. Huff will serve as the project manager. Thank you, Justine.
Thank you, Commission. I would also like to recognize from Pediatrics at Home, we also have John Adamovich, who's the Administrator for Innovation and Research, and Melissa Lance-Garnish, who's the Disease Management Nurse as well. So in the beginning of August, an announcement for grant applications was released. The announcement detailed a two-part application process, a letter of intent phase, and the full application phase. At the end of August, 9 letters of intent were received, and following a panel evaluation, 7 organizations were invited to submit full applications. The applications were due at the end of September, and a panel consisting of MHCC staff, CHMH, and a clinical provider evaluated the applications and identified 2 candidates with whom several interviews and site visits were conducted during November. At the end of this process, Johns Hopkins Pediatrics at Home was selected to receive funding to tests mHealth on pediatric asthma patients served by East Baltimore Medical Center. The use case aims to empower patients to manage their conditions to reduce hospitalizations and ED visits due to asthma, which is the third leading cause of hospitalizations among children. Over the past 10 years, there's been an increase in the use of mobile communication devices. mHealth aims to leverage the ubiquity of these devices to deliver health services that encourage patients to take a more active and engaged role in their health. Some examples of mHealth include targeted text messaging, patient reporting of health data through mobile application or through syncing with a wearable device, and real-time support from a provider or health network. The aim of the grant is to demonstrate the impact of use cases that allow consumers to take more responsibility for their health, increase access to health information and education, and improve communication between consumers and healthcare providers. This can facilitate improvements in public health and access to health services, as well as reduce healthcare costs. Applicants were required to address several key areas in their application. One key requirement was that the use case must be innovative and unique and not similar to previously funded telehealth grants. The applicant is required to establish goals for the project that are able to be measured and report on the progress of these goals along with implementation milestones on a monthly basis. At the conclusion of the grant, a final report is submitted that details the results of the project as well as lessons learned from implementation. The report will be used to support future mHealth implementation and policy efforts. In addition, applicants were required to provide a detailed sustainability plan to ensure continuation of the program following the grant, and are also required to provide a 2-for-1 match of the grant funds. I'd now like to turn it over to Susan to say a few words about the project.
I'd just like to start by thanking the Commission and saying how pleased and honored we are to receive this award and excited to pilot this project on the pediatric asthma population in Baltimore. So in summary, we're working with our partners at Johns Hopkins Community Physicians Practice and the East Baltimore campus. We had a lot of interest from physicians across the health system, but this group really stepped up to the plate and was able to identify patients right away that they believed would be eligible for this type of application and project. And it made sense for us to work on a pilot project to be very focused, not only in the inner city, but also to be focused with one group that could help us identify patients and get through this in a short period of time. So the Asthma Action Plan is developed by the pediatrician, and it's used by families and also the school system, and we'll be putting this plan in a mobile format. And it's very interesting because our design is really looking at engaging the actual patient, also the parents, but more our focus is mostly on the school-age child and the adolescent in learning more about their disease and engaging them in following the action plan and measuring things, everything from the amount of time that they engage in the app with the nurse and the communication that goes back and forth, pushing out education, tips, monitoring medication, and ultimately, of course, hoping to prevent emergency room visits that lead to costly admissions. But really, this project is a pilot and a feasibility study to look at the engagement in this type of format to the patient. It includes weekly check-in assessments, nurse monitoring, which Melissa and her team will do, and through our electronic medical record system within our health system, everything is going to be fed directly into and accessible that the pediatrician will have input and see as well. So it's exciting, it's different. We're looking forward to pilot living on these patients.
Thank you. So the technology partner is Quantified Care, and they are a Baltimore startup that spun out of Johns Hopkins University. The proposed technology will modify an existing platform and customize it to be used with pediatric asthma. Patients will be able to use this platform, as mentioned, to securely communicate with the nurse, complete the weekly health assessment, manage their medications, and facilitate use of their customized asthma action plan. Patients will also be able to access educational information such as videos through the platform. The technology will send push notifications to patients to complete the weekly assessments and for medication reminders. And it will provide alerts and tips to help the patient manage their asthma, for example, in response to environmental factors such as elevated pollen levels. The project requests $100,000 for 18 months. So Pediatrics at Home, as mentioned, is part of the Johns Hopkins Home Care Group. They mainly serve Medicaid and Medicaid managed care organization patients. And Pediatrics at Home routinely seeks grant funding to assist with initial program implementation in order to demonstrate the value of new programs. Pediatrics at Home is currently engaging in conversations with priority partners and CareFirst to increase reimbursement to sustain the program following the grant funding, provided the program shows to be successful in meeting the project goals. So after the grant is finalized, the project will kick off in early January and go live with the project protocols in April of 2017. The project will continue through July of 2018 when the final report will be submitted to MHC. Thank you very much, and we'll be happy to answer any questions. Any questions? Yes.
Just a logistical question. Does this give 24/7 access to a nurse or a pediatrician at any time?
At the pilot phase, it does not give 24-hour access. That would be our goal if we're successful in this realm. We didn't have the funding to implement the 24-hour. This is going to be through 8 o'clock in the evening, so from 8 through 8 o'clock in the morning, it will not.
But would you anticipate any abuse of this communication between the provider and the patient? Me being a private practitioner myself, I can see unlimited access to me would be problematic. The question is, if the mother of a child with asthma, is very upset 5 times a day about her kid, is she going to call the nurse or the doctor 5 times a day?
So she'll have access to us. You're going to introduce yourself. Oh, I'm Melissa Lance. I'm the case management nurse. I will manage the patients on this program daily. The patients will have access to us all day, during the daytime hours. Part of this program is teaching them what to do should they have an emergency. They already have access to their physician 24 hours a day, 7 days a week. There is on-call services provided by their physician. So during the time that they're on the program with us, they know they can call us. Certainly, they should call 911 for any kind of distress or emergency type situation. But we also instruct them that when we are not available, by all means, they need to call their doctor so they can get a hold of, or 911 should there be an emergency. So they always have access to a healthcare provider.
So education will limit the number of times they will call you.
Some people just need to talk and understand a little bit more, and sometimes it is just all about reaching out and talking with the patient and helping them understand. So we'll see what this brings.
So I like new and exciting. I've got my smartwatch on. It has told me to stand up several times and breathe and all these things. This is great, so it puts the responsibility on me, and a lot of what you're describing is how these patients can take more control over their asthma. So correct me if I'm wrong about triggers in the inner city of Baltimore. You mentioned pollen. Pollen happens. But some of the literature talks about rodents, roaches, vermin of a variety of types. So my question is, I'm just asking, because I like the exciting new things. If my asthma is being triggered by this toxic environment I'm in, what, if anything, do you do?
So
So also built into the program is, during the onboarding and assessment phase, is a home evaluation assessment and access to respiratory therapists. And if during this time of patients that are identified meet criteria and are on this mobile application program run into consistent issues where it's identified they need more than the mobile application program, then that would kick a referral to our program within our Pediatrics at Home system, which would could indicate a need for more frequent visits to the home or more environmental assessment. So we do have built in, when we do that environmental assessment, will be recommendations that might address some of those environmental needs. And you are correct that there, the research and literature shows that there's certain aspects of the environment that are most contribute to the reoccurrence and the effects of asthma. So we are taking that into consideration, and it's going to be something that we're evaluating.
So all I'm saying, I like it, and if it's collecting data on all my physiological parameters, it can also collect data on my environmental triggers. That data could be very important in remediation that may need to happen from someone who's not a physician, but someone who's an attorney or someone who's in housing. I would not want that to be lost. I'll be watching for that as you come back with your evaluation.
Thank you for that. Other comments?
I just had a question on what are you measuring? I mean, like sort of when you go through the project at the end, what is it that you'll be measuring when you come back and say, see, it was a success, it worked? What are the parameters? Is it engagement? Is it particular outcomes that you're looking for?
We have several different KPIs, but for the feasibility study, we are measuring engagement. And we will be also looking at these patients, their history 2 years prior to coming into this program. So we're going to, our initial hope for this project was we had a lot of high expectations of immediately addressing the needs and going after the high-risk population and decreasing admission visits and things. And what our feedback from those that are already doing research on this population in the city, many of them are our colleagues at the University of Maryland and Hopkins, and the pediatricians taking care of these patients, are those lofty goals are a few years out. That what they would really see, and our payers commented on this as well, is they want to see if this type of format engages this population. That could then lead to some additional outcomes. So we do have built in our KPIs that we are going to be evaluating those pieces. Having access to this population at JCC gives us the ability to be able to look at, here's someone, how many admissions did they have 2 years ago compared to this 18 months that we're following them. But our main goal is to look at the feasibility of this modality. And, are they accessing when the nurse tells them, go ahead and look at this and read this? Are they doing that? Are they answering us back once a week? Are they filling out how many times are their medications refilled? Are they answering when, the conversations back and forth? So that's originally what our goal is to look at. I want to ask a question in regards to, is the main audience that you're targeting as far as the conversation with the patient? Okay. Yes, but we have built into our consent, because we've gone through our IRB and everything. Obviously, there's going to be consent. And in the beginning, we are going to give an option to the parent and the child. There's going to be a format where the nurse is going to know whether she's talking to the parent or the child. So there's going to be the ability to have identify a primary user. So I used to work for the American Lung Association. I used to run the asthma camp. And I think this is a huge thing that gets lost a lot, that we forget that this disease is a patient's disease, not the parent's disease. And it's not until the patient takes accountability, responsibility, and taking the information in that they actually have positive outcomes in their lives. So I think it's awesome. I just, from a communications point of view, just want to point out that talking to kids, is different than talking to parents, and the words and how they phrase, etc. And everything that we are in the process of developing is age-appropriate language, conversation, text, videos. We actually have already had a focus group and brought teams in and all the age groups in to say, what do you think about this? And little things like we want emojis, we don't want, we want videos from YouTube because we're already on those applications and it's easier to access. They gave us really good feedback.
Do they have a way to share information also? Because in the spectrum of communications, the point at which they start sharing the information with others is the highest point of knowledge. Is there a way for them to do that?
Monitoring the way they're sharing the information they learn with us, with their peers and others.
Like when they have a
like
video
showing up on
that they think is
Snapchat
cool,
and
can they forward it on Snapchat?
We've talked about that. I have to tell you, we've talked about that in our design. That would be great if this was implemented in some of those social media formats where if you use it, it shows up. But so we talked about it, but
be able to
right now it's not in the plan.
That's just in the spectrum of knowledge. That's the highest form. So that'd be very interesting. Thank you.
I want to go back to what Commissioner Thomas raised. I had asthma when I was much younger. I know exactly how horrifying that disease is when you can't breathe when you're 11 years old. So I know all about it. In my case, it was fortunate. My asthma was brought on by various types of allergies that largely disappeared with age. But in any event, in some circumstances, these conditions are basically within the confines of human decision making. And what I'm talking about in particular is the inability or the unwillingness of either landlords or the public health department to do what they're supposed to do. If you have a situation where we can trace the onset of pediatric asthma to something like the presence of rodents or rats, well, damn it, you got to kill the rats. Now the thing is, do you guys have a plan? For example, this is following up with what Commissioner Thomas was saying. Do you have some kind of a plan to contact like the health department or, okay, this is all I wanted to know. I'm going to close the circle on this. So if you find some cases where, in fact, this is really the serious problem, then you guys will, in fact, do precisely that. Follow up with the appropriate authorities. I'm not expecting you to do it, but follow up with the appropriate authorities to get it done, right?
And yes, and Melissa will answer, but we are familiar with that model in our home care practice.
Right.
Patients that do not have it.
No, this is.
So I'm just telling you that yes, we recognize, and you can talk about
it.
Along with our adult population, this is something we deal with now.
Right.
Those folks. So we're fortunate enough that these patients will be within our health system, and most of them will have hopefully case management, or we will get them into it. So we will all circle around that patient, do whatever we need to do to help them get what they need from all angles, so that the environmental concerns, no matter what they are, pollen, like you said, is one thing, but it's where they're living too.
That's
be able
right.
to address those, whether it's even, the sheets they're sleeping on or not sleeping on, or things like that. And housing situations.
I think.
Yeah, we're going to wrap around. We
Good.
wrap around with case management with the patient. And
Given the fact that we're talking about our responsibility for the grants, I think in our view, we would like to see that there was compliance on the part of other parties that you were dealing with. So at least as a public body, we have our responsibilities. We can certainly respond to that in some kind of an official way, and that's why that's really critical. All right. Thank you very, very much. I just wanted to make sure we close the loop on that.
And we love the nurses, okay? But we're counting on you because these individuals, in a sense, become data collectors about that environment. You have a tremendous amount of clout with the organization you come from. It needs to be used in a way that remediates some of these root causes. And you're going to have the data and make sure that that's part of what's also being collected. You've got a chance to do this now. Just
quick question. Does this mHealth involve video communication too? I think you mentioned video. So it does. Okay, because you can just taking a look at a kid, the way he breathes tells the whole story in an instant. So thanks.
Very inspiring presentation. Thank you very much, and good luck to all of you. Thank you. So we bring ourselves to that point every month where we ask Ben what's coming next.
What is
overview of upcoming initiatives aside from 2017? So Ben.
First off, I want to wish you all a very delightful holiday season. In January, we can promise that we've been talking about the total cost of care initiative that we've been doing in collaboration with 6 other regions. We're hoping that RWJ will give us authorization to release it and share with you the results. Total cost of care is built into the DNA of Maryland today, but what we don't have is results from across the country because, Dr. Pollack aside, they're a little bit behind us there. So we're hoping to do that presentation. It's premised on the fact that RWJ, who is the funder of this project, will sign off on public release. On that note, Linda and her team are in the midst of submitting a small grant to ENRI to continue that work, to continue to benchmark Maryland against other regions of the country, and I think it has a lot of promise. We are anticipate engaging some additional practices beyond the 3 that participated last fall in looking at how these total cost of care metrics developed by health partners in Minneapolis could be used, and I think that will be a very informative presentation. We'll have more of the same from David and his team on this time not the mobile health but the traditional telehealth grants. I think as you're, if you have a spare moment, one thing that is of concern to me is that we are now planting the seeds for a lot of telehealth initiatives, but we don't have long-term funding. We can depend, and CareFirst has been a very generous funder of some telehealth initiatives, in fact, in collaboration, carry them forward. But it is not enough just to have grants if they can't be taken to scale. And I think where we see the most promise, notwithstanding this really good, positive presentation today, is in these telehealth collaborations between nursing homes and hospitals. Clearly there, the discriminator in my mind is the motivation of the nursing homes themselves, that those that seem to be most successful are the nursing homes that really want to move these forward. Hospitals are generally very positive because of financial arrangements they're operating under. So we'll see more of that. And then lastly, we expect to have several very significant CON projects for the Commission to review in January, and we'll keep you posted, and we'll get documents on those. Feel free over the holidays. If that material comes out, just email me or Sue Ellen with any questions you might have.
Ben? Entertain a motion to adjourn?